In this session, we're going to be covering stroke. And specifically, we'll look initially at the epidemiology, the risk factors and the consequences of a stroke, before thinking about the pathophysiology of the two main types, that's ischemic and haemorrhagic stroke, and then talk about diagnosis and management. So, of course, a stroke occurs if blood flow of oxygen-rich blood to a portion of the brain is blocked. That's otherwise known as a cerebrovascular event because it's the vascular system that is being affected. So, of course, if we're looking at Australian stats, it's about every 10 minutes that an Australian will have a stroke. 434,000 or so Australians have an irregular heartbeat, and there's about 5 billion is what the strokes cost the Australian economy per year. And related to that, of course, is we've got 6 million Australians have got high cholesterol levels, which are more likely to give you atherosclerotic plaques, and that's a major event or a major risk factor in the development of a stroke. So when we're thinking about cerebrovascular events, we're thinking that an artery supplying the brain is altered due to a lack of blood flow to it through ischemia or through bleeding, so therefore a hemorrhage, causing disruption of oxygen delivery to that portion of the brain. Neurons die very quickly, and they don't regenerate, hence the name cerebral infarct, which, remember, of course, infarct means death. And there are two main types. So you've got hemorrhagic stroke. And so your hemorrhagic stroke is basically where you get a blood vessel bursting. The blood vessel bursts and the blood bleeds out of the blood vessel and into the surrounding tissue. And in this case, of course, we're thinking it's bleeding into the brain, and the blood itself is very toxic to neurons. And so it obviously causes them to die very, very quickly. You then have an ischemic stroke, and that's where you may have a blood flow blockage, so atherosclerotic plaques, and you get a rupture of a plaque and a clot forming, leading to an ischemic stroke. So in this diagram, the ischemic stroke is occurring in that little area, leading to a lack of blood flow downstream. About 80% of strokes are ischemic, and about 20% of are hemorrhagic. And as you may be able to guess, hemorrhagic strokes are generally much nastier to have than an ischemic stroke. If we want a definition of a stroke, it's defined as the sudden onset of a neurological deficit attributable to a vascular cause. But really, we're just thinking a lack of blood flow to a portion of the brain. So what do you think the major cause of an ischemic stroke actually is? Well, hopefully you already know this because we've talked about it. Of course, it's atherosclerosis is the major cause. So who are more likely to have a stroke, are males or females? Well, males are more likely to have a stroke. And this is just a diagram showing the age group characteristics of male and female likely to have a stroke. So it's pretty uncommon in people under 50. And as you get older, the proportion of people getting strokes increases dramatically. And you can see that and 85-year-olds and plus and 75-year-old plus, you're getting a significant number of both males and females having strokes, but proportionately greater number of males. So 80% of all strokes, as you can guess from this image, from this diagram, occur in those who are over 60 years old. 40% of stroke sufferers die within 12 months, and there are about 420,000 Australians currently living with a stroke, so who've had a stroke. And it's estimated that by 2032, more than 700,000 Australians will be living with a stroke. That's 2.5% of the population. And a third of stroke sufferers have significant disability, and that accounts for about 7% of all disability. So in other words, what we're really thinking is as the population gets older, we're more likely to have more and more people having a stroke. And so 1 in 6 85-year-olds and over have had a stroke. There are more than 1,000 people having a stroke each week. And as we've said, over 40% of these die within 12 months. And those that don't die, a significant number become dependent on carers. So bearing this in mind, stroke is obviously a leading cause of both mortality and morbidity. And there are a series of risk factors, so the ones we can't do anything about, so things like your age. So as you get older, you're more likely to have it. Things like being male, you're more likely to have a stroke. Genetics, again, you can't do anything about your family history. And age, as we've seen, is one of the most significant risk factors out there. So what are the major modifiable risk factors? Well, the major modifiable risk factors, things like smoking, obesity, poor diet, lack of exercise, alcohol, stress, and diabetes. But the biggest ones really is hypertension. This is the biggest one likely to cause a stroke to occur in the first place, and heart disease and dyslipidemia. And so any number of modifiable risk factors, as smoking, obesity, poor diet, can lead to your hypertension, heart disease, dyslipidemia. And as I said, hypertension is the greatest risk factor. If you're looking at the top 5, if you wanted to put them in order, you'd have hypertension, smoking, abdominal obesity, diet, physical activity. And those together constitute about 80% of the global risk for both stroke etiologies. What about the blood supply to the brain? So obviously we're thinking about vascular events occurring in the brain, so you need to know a little bit about the blood supply to the brain. And we're not going to do that in any great depth. But neurons have a very high energy, so ATP and oxygen demand. They don't have energy reserves, and they don't have myoglobin, unlike skeletal muscle. And of course, myoglobin is an oxygen reserve. So you have myoglobin in your skeletal muscle, it carries one oxygen molecule, and it's there to be used when it needs to be. The arterial blood reaches the brain through 2 internal carotid arteries and 2 vertebral arteries, which go on to join and form the basilar artery. And you can see this in this little image here. You can see the internal carotid artery, the middle cerebral artery, and the circle of Willis. So this is obviously the bottom view of the brain. And there's your basilar artery. And these are all interconnected, as we've talked about, at the base of the brain to form the arterial circle of Willis. And the original thoughts, if you want to call it that, was that the circle of Willis would allow blood to pass from one system to another in case of blockage. I don't think that's necessarily thought to be one of the reasons anymore, but it's a fine little theory behind it. And of course, most venous blood leaves the brain through the internal jugular veins. But how much blood is actually pumped to the brain every minute? Well, you're getting about 750 mils of blood being pumped to the brain. And if you get circulatory interruption of just 5 seconds to the brain, that can lead to unconsciousness. 20 seconds can lead to a reduced electrical activity in that area. And 5 minutes, as little as 5 minutes, can lead to irreversible brain damage. So some of the consequences of a lack of blood flow to the brain are very, very significant. So what are some of the consequences? So the affected brain area can't function, causing neurological damage and complications. So if you get a stroke in different areas of the brain, you have different effects. So I'm going to get you to think, here are some of the main areas of the brain. So you've got the area for sight, touch, movement, your personality, hearing, your Broca's area for speech, Wernicke's area for understanding language. Remembering, of course, that to understand language, you have 3 different things. You have vision, you have sound, so hearing, that's how you understand language, but also touch, so which is up in this section. And Wernicke's area, that integrates all of those 3 senses together. So sight sends information to Wernicke's, touch sends it to Wernicke's, and hearing sends it to Wernicke's. And Wernicke's brings that all together to understand language. So if we're looking at each brain region, I want you to tell me what the effect of stroke would be in each little area. So what would be the effect of a stroke on the motor area in the right hemisphere of the brain? Remember, the brain is separated into left and right hemispheres. The cerebellum, you need to know what the cerebellum does. Broca's area and Wernicke's, they're both up there. Your various senses, your frontal lobe, which is shown there. So that's where you're in here, it's written intelligent personality traits. And your brain stem, which has got a lot of the control centers. So your respiratory centers, your cardiovascular centers, your vomiting centers, all swallowing centers, all manner of centers are being controlled through the brainstem. So press pause and have a little bit of a think. Okay, so if you have issues in the motor area in the right hemisphere, you may get weakness of the left arm, left leg, and face. Side of the face, you may get drooping on that side of the face. And that's because the right side of the brain controls the left side of the body. Cerebellum. Cerebellum is all about coordinated, smooth movements. So if you affect cerebellum, you get unsteadiness, poor coordination. Broca's area is all about speech, so you may have difficulty speaking. Wernicke's is about understanding language, so you'll have difficulty understanding speech and the written word, so understanding language. Senses. So you may get or variety of senses may be affected. So sight, hearing, touch, and other sensations may be diminished. Frontal lobe, you may get cognitive impairment, behavior changes, depression, and brainstem, of course, eye movement issues, but it's often fatal because of the key centers, control centers that are there, your cardiovascular center, your respiratory centers, for example. You get the eye movement issues, of course, because some reflex issues arise in the brain stem. So there are lots of other potential problems that people might have with a stroke. They include pain, problems controlling feelings, incontinence, paralysis. But overall, there's a significantly increased risk of death. So the second part that we're going to look into is looking at the pathophysiology of both ischemic and haemorrhagic stroke. So if we're looking at the two different types, your thrombotic, you've got your thrombotic and your embolic strokes. So those are ischemic. And so remember, thrombus forms in one place and blocks that particular place. So it forms in the brain and blocks the brain. Embolic, the clot is produced in one place and moves somewhere else. So it breaks away and flows to the brain, where it causes an embolic stroke. And you've got cerebral hemorrhage, where you're getting bleeding onto the brain. So in a weak patch, usually in a weak patch in the blood vessel, which is called an aneurysm. If you're looking at the amounts, your ischemic stroke is by far the most common at 80%, thrombotic, of which thrombotic of 50 and embolic 30. And of course, your hemorrhagic stroke therefore makes up your 20%. Your hemorrhagic stroke, as we've already talked about, that is really due to bleeding from the cerebral vessels into the brain tissue. And as we've talked about, it's less common, but is more likely to be fatal. In particular, because you can get compression of the brain tissue with blood, which further compromises its function. So let's look at ischemic blood flow. And this is often due to sudden obstruction to a cerebral artery, which results in associated atherosclerotic plaques because of atherosclerotic plaques. So that sudden blockage, the cerebral vessels supplying the brain becomes supplied by the artery, becomes ischemic. And if the situation doesn't improve rapidly, the infarct can occur, which is your death of your neurons, of course. Where is the most common place? Well, the most common place is in the middle cerebral arteries, which is just shown just off the circle of Willis. And again, it may be thrombotic or it may be embolic. A transient ischemic attack, which you may well have heard of, or a transient ischemic event, that's a temporary change in blood flow to the brain. And it's basically a brief stroke-like attack that resolves within minutes to hours. And a TIA can cause a brief change in brain function. So it may lead to vision issues, speech issues, dysphagia, dizziness, loss of consciousness, unsteadiness. And a TIA does require immediate medical attention to actually distinguish it from an actual stroke. It's usually a very positive indicator towards underlying thrombotic disease, and it therefore increases your stroke risk. And as we've already said, they usually resolve within 24 hours, leaving no dysfunction or permanent brain injury. And as we say, generally within the first hour, they're often reserved. But it is a serious warning sign for another TIA or potentially a stroke. And they often occur quite soon after the first TIA, so 24 to 72 hours after the initial first TIA. So what actually happens with an ischemic stroke? Well, that reduction in blood flow to the brain tissue results in energy failure at the cellular level. In other words, you're not getting the nutrients and the oxygen to that part of the brain, so it can no longer function correctly. So that artery blockage, often down to an atherosclerotic plaque that is ruptured, means there's a lack of blood flow to the distal part of that brain tissue, so further downstream of where the blockage has occurred. You start to get neuronal cell ischemia, you start to not have enough energy, enough ATP, so your pumps no longer work, your sodium-potassium pump to maintain the electrical gradient within the neurons. And if they're not working, of course, you get neuron malfunction, and therefore that leads to neuronal cell death. At the same time, that neuronal cell ischemia leads to the buildup of toxins and acids, such as lactic acid, which damages the cells, leading to neuronal cell death. So what's actually happening? As we've said, with circulatory interruption, 5 seconds can lead to unconsciousness, 20 seconds to no electrical activity in that area, 5 minutes, irreversible brain damage in that area. So strokes are very, very serious and need to be dealt with very, very quickly. We'll next look into hemorrhagic stroke. And in hemorrhagic stroke, we've got it due to a rupture of a cerebral artery, which results in tissue hemorrhage. And so therefore the blood escapes into and around the brain tissue. So it's actually released onto that brain tissue. And it starts to compress that brain tissue and can displace that brain tissue. And that increased intracranial pressure that's occurred and local compression of that tissue can displace it, so push it to different places, leading to neuronal infarct. But at the same time as this toxic blood, if you like, because it's got lots of nasties in it, it's got urea and stuff in there. This nasty blood is really damaging to the neuronal cells, to the neurons in your brain. But as well as that, the loss of blood means that you're disrupting blood flow to distal to that infarct place, to the rupture rather. So again, this part is very similar to what's happening in ischemic stroke, where you're getting a lack of nutrients going downstream to the place of issue, if you like, rupture or ischemia in the other case. So it's a lot more significant because you've got blood going onto the brain tissue itself. So the symptoms include a very severe headache, vomiting, rapid loss of consciousness, can lead to deep comas, irregular respiration, dilated, non-responsive pupils. And really the whole point is that the blood is extremely irritating on that brain tissue, which can lead to further inflammation and further swelling, which exacerbates that increased blood pressure. And therefore, as you might expect, it's got much higher morbidity and mortality because the hemorrhage can greatly displace that brain tissue. So you can actually see a shift in brain materia inferiorly or laterally, which of course can affect functions at quite some distance from the actual rupture itself. So what are some of the risk factors for hemorrhagic stroke? Well, they include chronic hypertension, one of the greatest risk factors, the greatest risk factor for stroke in itself, but also aneurysms, so those weak patches in the blood vessels. And so, of course, the chronic hypertension, the degree of pressure on artery walls is a contributing factor to their rupture. The more pressure on them, the more likely they are to rupture. And an aneurysm, these are structural weaknesses within the artery walls themselves, and they can form for a variety of reasons. But the presence of these weaknesses, they can remain undiagnosed until one ruptures, and some people might actually live out their lives without incident, even though they've got plenty of these ruptures, of these weak aneurysms in place. And most of these cerebral aneurysms, these weak patches, they occur at bifurcations, and that's those blood vessel branches in or around the circle of Willis. And again, that's just because as the blood's coming in, you have this turbulent blood flow. Turbulent blood flow as it comes in, causing an aneurysm. Turbulent blood flow causing an aneurysm. Turbulent blood flow causing your aneurysms. Okay, so that's where the aneurysms tend to occur, and therefore where they're more likely to rupture. So what I'd like you to do now is just complete the following table, comparing ischemic and hemorrhagic stroke. So press pause and try and answer the questions. Okay, ischemic stroke. Total, 80%. Hemorrhagic, 20%. Morbidity, so we want less or more, so to speak. Morbidity, ischemic stroke compared to hemorrhagic stroke, less. Hemorrhagic, more. Mortality, less and more again. Major risk factor for ischemic stroke, atherosclerosis and hypertension. Hemorrhagic stroke is aneurysms and hypertension. And the pathophysiology, well, we've talked about this already. So in ischemic stroke, you get an artery blockage, leading to a lack of blood flow to the part of the brain distal of that blockage, ATP depletion, toxin accumulation, and neuronal cell death. And in hemorrhagic stroke, you get bleeding on the brain, leading to an increase in intracranial pressure, which can lead to brain compression and alter brain function. But also, you're getting a lack of blood flow to the part of the brain distal to that bleeding, to that hemorrhage, leading to ATP depletion, toxin accumulation, and neuronal cell death. And it's a lot more complex. You can go and look into the mechanisms of this in a lot more detail if you wish. So the last little bit we're going to cover in this session is looking at the diagnosis and the management of stroke. So we have two different zones, or two primary zones of infarct. The primary zones, so that's shown in the darker green, are the zones immediately affected areas. They're irreversibly damaged and they are replaced with scar tissue. And so these primary zones generally have blood flow below 10, 15, 20%. Therefore, we're having rapid ischemia and necrosis. The secondary zone, otherwise known as the penumbral zone, is the area around the primary zone. This is where injured neurons may recover if blood flow is restored quickly. And of course, the faster the blood flow is restored, the less permanent the damage is. Where do you think most pharmacological drugs are effective and why? Do you think it's in the primary infarct zone or the secondary infarct zone? Well, it's actually the secondary infarct zone or the penumbral zone. And that's really because you've got less severe damage. It hasn't occurred as quickly in those points. So it may be possible to salvage cells potentially within the severely ischemic course of the primary zone, but it's a lot less likely. Of course, when we're looking at diagnosis, the faster the diagnosis, the faster the treatment, the less permanent damage is likely to occur. And there are those classic symptoms that you should be looking for. You'd look at the face. Has their mouth drooped? Have they lost that muscle tone there? Can they lift both arms? Are they able to speak? Thinking about Broca's area, and time is critical. We know now 5 minutes and the neurons are dying. So you've got to act very, very quickly. These aren't the only potential symptoms, but they're some of the classic symptoms that people recognize. Can you remember some of the others that we talked about, depending on the area that's affected? So people might have difficulty speaking or understanding language, loss of balance, poor coordination, loss of vision, headaches, difficulty swallowing, personality changes. They're all manner of potential symptoms that could be due to a stroke. So therefore, the patient's medical history is important, in particular because hypertension is the main risk factor for hemorrhagic stroke in particular. So how is it managed? Well, ischemic stroke requires restoration of blood flow as quickly as possible and prevention of ischemic injury. And we have clot-busting drugs, TPA, for that. Okay, and they're used to dissolve clot and minimize long-term damage. And basically, as it says up here, you drip in the clot-busting drug TPA directly onto a clot through a catheter, and it basically dissolves that clot very, very quickly. They do have to be given quickly, as you might imagine, because of the potential damage, and they tend to need to be given within 3 hours of stroke to give the most effective results. TPA, does it say what it stands for there? No. So TPA stands for tissue plasminogen activator, just so you know what it's called. You can give anticoagulant therapy over the longer term, so antiplatelets, so aspirin. You need to control your risk factors, so a healthy lifestyle. And hemorrhagic stroke is most likely to be treated with surgery. Remember, this way you're getting bleeding onto the brain. So you need hypertension control, you need diuretics to reduce that intracranial pressure. And of course, they'll use anticonvulsants often to prevent seizures.